Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello and welcome. I'm Dr. George Wolters, President of the Pennsylvania Osteopathic Medical Association. Today, I'm pleased to sit down with Tyler Burke, our Senior Director of Government Affairs, for an important conversation about recent developments in Harrisburg surrounding the CRNP independent practice. These proposals have significant implications for our profession, our patients, and the future of healthcare delivery in the state of Pennsylvania. We'll discuss where things stand, how we got there, and what osteopathic physicians need to know about the ongoing debate. I hope this discussion provides valuable insight and context to all of our members and listeners about this important topic. Mr. Burke.
Dr. Wolters, thank you so much for having me. As I sit here, I would like to make the joke that it is June 39th. House and Senate have yet to come to a concurrence on a budget for the year. So while we are having this discussion, I do just want to put the context that the House and Senate are still working on a budget and that there are things still up in the air. And like anything in advocacy, when we say it, it might not be true the next minute. So just take a listen to this. This will provide some background and context for all of our listeners. But if you want the more up-to-date information, always feel free to reach out to me via email or my cell phone, which will be in the podcast description.
Speaking of historical context, over the past few decades, how has the scope of CRNP practice evolved? And what were the major milestones?
So let's start with Pennsylvania. In Pennsylvania, there has been limited expansion of CRNP scope over the past few years. The most notable expansion was the formalization of the collaborative agreement, which allowed CRNPs more autonomy while still requiring an ongoing relationship with a supervising physician. This model aimed to balance expanded access to care, especially in underserved areas, with oversight to ensure patient safety. This is the system that we still practice under in Pennsylvania. Now, when we look nationwide, that's when it's a completely different story. Across the country, there have been rapid expansions of nurse practitioners over the past couple decades. We have seen 27 states grant CRNPs full practice authority. That means that they can practice independently without physician oversight, removing the care team model from healthcare delivery in those 27 states. This increase in autonomy across the country has ramped up pressure on Pennsylvania to expand CRNP scope of practice. This pressure has resulted in several attempts over the past 10 to 15 years to pass full practice authority. While none have been successful, different proposals have gained momentum in certain sessions, reflecting the national trend. In my mind, the 2019 compromise was the closest CRNPs got to increasing scope of practice in Pennsylvania.
And what was the 2019 compromise?
The 2019 compromise was the result of months of negotiations and discussions between physician stakeholders and nurse practitioners to create a pilot program to allow certain CRNPs, those who have practiced for 3,600 hours or more, to practice independently in primary care health professional shortage areas, HPSAs. Included in this pilot program was a mandatory oversight committee made up of both CRNPs and physicians. This was there to oversee the pilot program and make sure that the CRNPs participating in the program were properly educated and had guidance as to what to do in the pilot program. I do just want to note the compromise did fall apart as it was initially supported by all groups, but as it made its way out of the House and into the Senate, the CRNPs did pull their support from it, and that is why the 2019 compromise is not law.
In the most recent compromise, the 2025 proposal to expand CRNP scope of practice, what did it include and how did it differ?
So the most recent proposal that was floated really built on that 2019 compromise. The main difference between the 2019 compromise and the 2025 proposal was an expansion of the eligible practice areas. So back in 2019, you had those HPSA areas that really hit rural and underserved Pennsylvania. If you looked at the 2025 proposal, it would have expanded into medically underserved areas. And medically underserved areas is a much more loosely defined term. And when we saw the impacts of that on the map, we saw a 500% increase of practice areas for nurse practitioners during the pilot program, and the inclusion of the MUAs would move them into areas such as Philadelphia, Pittsburgh, and moving them away from the heart of the CRNP's advocacy that when independent practice is granted, they will come into underserved areas and alleviate shortages of care. So that really just muddied the water. And then another big concern for us was the removal of that mandatory oversight committee. That mandatory oversight committee is something that we believe is vital to the success of the pilot program to make sure that it is done right and that information collected is done with the guidance of physicians.
From your perspective, why is the issue coming back up now, and what factors are driving it?
It's a Band-Aid fix. Pennsylvania and the country as a whole are currently facing serious challenges in our healthcare system. These issues show up every day as a lack of access to care, long wait times, and provider shortages, especially in rural and underserved areas. Rather than investing in comprehensive solutions like expanding residency slots, supporting physician recruitment and retention, or improving reimbursement for primary care, some see expanding independent practice for CRNPs as a quick and low-cost fix. It shifts responsibility away from solving the underlying workforce and funding problems while letting policymakers claim they're improving access. That's why the issue keeps resurfacing. It's an appealingly simple answer to a complex issue. And when we look at it and the 27 other states, it is not the silver bullet that solves access to care.
Agreed. How are other physician organizations and nursing groups responding to these proposals? What are the main points of disagreement? And I'm glad you're answering this one.
Yes. POMA has reviewed the proposal and provided comments to legislative staff that indicate we find the changes too expansive but are willing to come to the table. One of the things that I do want to put out is that while POMA might disagree with many things in the 2025 proposal, we will always be at the table and in good faith negotiating on behalf of our patients and members. We have been working with many physician stakeholders to ensure that there is a united front here, and it is very much anticipated that this proposal is not going to go forward due to the current implications with some of the stakeholder groups.
What does existing research or experience in other states tell us about the outcome of independent CRNP practice?
So it's very interesting to examine the academic literature surrounding this issue, because with so many other states that have granted CRNP independent practice, you would anticipate a much clearer understanding of what happens when CRNPs are granted independent practice. In the literature that I have personally reviewed, I have seen reports indicate that CRNPs order more tests and refer to specialists at a much higher rate. Outside of the academic literature, I want to mention a series of articles that Forbes did that looked at CRNP education and how CRNPs are utilized in independent environments. It was a really eye-opening article, and I will make sure that it's going to be linked in the description of today's podcast so that our members can take a read of this, because this is important information that I really didn't even know as dug in on this issue. And it's the lack of standardization in some CRNP education and what happens in those 27 states.
Last year, there was an article in Journal of Osteopathic Medicine that reinforced a lot of the concerns about independent practice. It was very well written, and I'd advise anybody to pull it up and look at it because it reinforces a lot of the points that you've made. Some have called for mid-ground solutions like collaborative agreements or limited expansions. Do you see any compromise proposals gaining traction?
So POMA remains at the table and willing to work on the current collaborative agreement structure in Pennsylvania. We see that there are improvements that need to be made, and we're always here and willing to do that. In terms of a middle ground for full practice authority, I think the 2019 compromise is probably that middle ground. There is an insistence among some groups of the CRNPs that it needs to be a statewide expansion. And as somebody who believes in incrementalism, a statewide expansion at that level without proper study is just not, in POMA's opinion, a compromise.
I'd like to thank Mr. Burke for his time and his comments on this issue. If you have any feedback or episode ideas, please email POMA@POMA.org, and be sure to subscribe to the POMA Does podcast series on your favorite podcast platform or POMA's YouTube channel. We'll see you next time. Stay healthy.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at POMA@POMA.org. We'd love to hear from you. Join us next time for another edition of POMA Does.